Welcome everybody to the May ERA Journal Club. Each ERA seminar usually takes place on the last Thursday of the month at 1700 Central European time, which is 1600 Oxford UK time, which is where I am based today. So each seminar has been picked out of a topic from a recent original research or key review article from Entity or CKJ, and the author or authors introduce their work to us. There's always at least one expert panel member. Today we're very fortunate to have two, and the Journal Club will be moderated by myself, Parminder Judge, and my co-host, Professor Will Herrington. We're both Oxford-based nephrologists, clinical trialists, and clinical kidney epidemiologists, and Will, as many of you will know, was the co-PI of the EMPA kidney trial. The discussion will be focused. It's usually fairly informal, and we encourage lots of lively and hopefully lively questions and debate from the listeners. And these can be typed into the Zoom Q&A box, and we'll answer them as we go along and at the end as well. So it's always recorded, and all of the presentations are made available on various video platforms afterwards. So please do keep an eye out on social media for the links. So today's topic will cover how best to decide on the optimal timing of vascular access surgery. And we know that this can be a very challenging decision, and many patients often initiate hemodialysis with a central venous catheter, which is obviously less than ideal, rather than having natural access, which in itself can be, starting with a catheter, can be associated with the risk of harm. So today's study aimed to assess the impact of implementing the kidney failure risk equation for planning the timing of creation and referral of vascular access. And this paper was actually published online in March. So I'm delighted to be able to introduce to you the first and senior authors of the study, Dr. Ulrika Hahn, Lundström, and Professor Marie Evans. And both Dr. Hahn, Lundström, and Dr. Evans are senior consultant nephrologists at the Karolinska University Hospital in Stockholm and undertake their research at the Karolinska Institute. Dr. Hahn has a particular interest in pre-dialysis and dialysis care, and this topic actually was the focus of her PhD thesis, whilst Dr. Evans also works and focuses on CKD prognosis and pharmacoepidemiology. So I'd like to take this opportunity to thank them on behalf of myself, Will, and all the ERA team for bringing their work to NDT, and also to this ERA Journal Club today. In addition to our two fantastic speakers, we're extremely fortunate to have two external panel members with us today, and I'm very grateful to Mr. Nicholas Inston, who's a consultant renal and transplant surgeon at the QE Hospital in Birmingham in the UK. He's very active in trials on vascular access as well as transplantation, and is the national clinical lead for organ utilisation of kidneys in the UK, and is also the current treasurer of the Vascular Access Society. And last but not least, I'm also extremely delighted and grateful to Professor Navdeep Tangri from the University of Manitoba, Canada. As many of you will be aware, Professor Tangri was instrumental and developed the kidney failure risk equation to predict the need for dialysis in patients with CKD, and is obviously ongoing work on multiple validation and implementation exercises to increase the uptake. So we have a fantastic and stimulating topic and world-leading experts available, a live presentation and discussion. So please do take full advantage of this and submit your questions into the Q&A box on the Zoom platform. Please don't be shy. So Dr. Hahn, Lundström, without any further ado, please do share your screen and start your presentation.
My disclosures are some lectures for Baxter and Fresenius Medical Care. I'm honored to present our study, Clinical Impact of the Kidney Failure Risk Equation for Vascular Access Planning, at this ERA Journal Club. Both myself and my supervisor, Dr. Marie Evans, are senior nephrology consultants, and we work in the Karolinska Rosenlund, our outpatient home dialysis unit here at Karolinska in Stockholm, where we are proud to have an extensive pre-dialysis program and a 40% uptake in home dialysis of PD and home hemodialysis. The gold standard vascular access for hemodialysis is an arteriovenous fistula or graft. Timing of AV access planning is challenging. Too many patients initiate hemodialysis in a central venous catheter. Risk-based thresholds for AV access referral have been proposed to aid the vascular access planning procedure. Here we aim to assess the impact of implementing the kidney failure risk equation for vascular access planning in clinical practice. This is an observational cohort study from the Swedish Renal Registry 2008 to 2018. We included 16,100 nephrology-referred CKD patients with eGFR 30 and below. We calculated KFRE repeatedly during continuously updated outpatient visits. The timing was identified when the KFRE risk exceeded several predefined thresholds, KFRE 30, 40, 50, and/or eGFR 15, based upon previous research. Cumulative incidence curves of KRT or death were computed at 6, 12, and 24 months. We then compared the utility using decision curve analysis. Last, the clinical impact of using the different KFRE eGFR thresholds was illustrated by an example from the Swedish Renal Registry dialysis access. The characteristics when patients first reached the different thresholds differed. Patients who first reached KFRE 40 were younger, more often men with more albuminuria compared to patients who first reached eGFR 15. Out of the 16,000 patients, 17% died and 18% initiated KRT within 2 years. The sensitivity, which means the proportion of patients who started KRT who had a positive test. As expected, the sensitivity at 12 months was highest for eGFR 15 of 81%, followed by KFRE 40 with 68% and KFRE 50 with close to 55%. Conversely, the specificity, meaning the proportion of patients who did not start KRT who had a negative test, was highest for KFRE 50 with almost 95%, KFRE 40 of 90%, and another 10% lower for eGFR 15 at 80%. The proportion of patients who started KRT within 12 months was highest for KFRE 50, 50%, followed by KFRE 40 plus eGFR 15, and then KFRE 40 alone. These numbers are comparable to the positive predictive value. As you can see, eGFR 15 demonstrated a much lower probability of starting KRT and a larger proportion of patients who died, 11%. The negative predicted values at 6 months were high for all the thresholds, 96 to 97%, meaning that there were very few patients who had not reached the thresholds that started dialysis within 6 months. The median time to KRT for those who started hemodialysis was about 1 year for KFRE 40 and eGFR 15 separately, and slightly shorter for KFRE 50 and the combined threshold of KFRE 40 plus eGFR 15. First, I'd like to explain something about decision curve analysis, since this may be a concept that you are not familiar with. Decision curve analysis is the statistical method for evaluating and comparing prediction models in terms of their clinical consequences. This is unlike traditional accuracy measures such as area under the curve, which do not take clinical considerations into account. Considerations such as it being worse to not place an AV access on time and start hemodialysis in a catheter than to do an unnecessary AV surgery in a patient that do not start dialysis. This relationship between the harm and the benefit of vascular access surgery needs to be individualized. Decision curve analysis evaluates the net benefit of a model in comparison to the two default strategies of treat all patients or no patients. In our study, to refer all patients or no patients to vascular access surgery. The decision curve analysis evaluates how the decision threshold perform across all harm-benefit ratios. In summary, it is the model with the highest net clinical benefit over the whole harm-benefit range that is the most optimal. Thus, the challenge is to balance the benefit from starting hemodialysis in an AV access against the harm of unnecessary surgery. Here you see the decision curve analysis for the utility of vascular access referral at 12 months. As you can see, the harm-benefit ratio to the left means that you prefer the risk of unnecessary surgery, and to the right that you prefer the risk of no AV access on time, for example, in a frail elderly patient who may not survive until start of dialysis, or where you expect the need of several interventions for successful AV access maturation. Close to the y-axis, you value the start in an AV access 100 times more than the risk for a catheter. To the far right, you value to start hemodialysis in an AV access equal to start in a catheter. Harm-benefit ratio in the elderly, where the risk of harm, unnecessary surgery, is higher, the use of KFRE 50 or the combination of KFRE 40 plus EGFR 15 is preferred in both 1 and 2 years. On the other hand, if your aim is to optimize the number of patients starting hemodialysis with an AV access, the best strategy would be to refer patients 1 to 2 years before KRT initiation at EGFR 15 or KFRE 30 if we consider it less harmful with unnecessary surgery than starting on a catheter at 1 and 2 years. In the Swedish Renal Registry, 54% of patients followed in outpatient care started hemodialysis in a catheter, and 46% started in an AV access. We could see that 23% of patients starting hemodialysis in a catheter had previously undergone AV access surgery. However, the surgery was only 52 days prior to hemodialysis initiation, compared to 158 days for those who started in an AV access. Only 5% of patients who started hemodialysis in a catheter had AV access surgery more than 6% before hemodialysis start. We also identified that 62% of the patients who started hemodialysis in an AV access had a KFRE over 40 12 months prior, compared to 60% among those who started in a catheter. Thus, 1 year before start, there were no major differences in the proportion of patients identified with KFRE 40 based upon the kidney failure risk equation. The challenge is to identify patients being at risk for starting hemodialysis. Evidently, this has not been the case in Sweden, and this is although the information was present. If KFRE 40 would have been used for clinical decisions regarding AV access planning, an additional 60% would have been identified in time. In conclusion, our study demonstrates that the utility of a risk-based strategy is higher compared to the more traditionally used EGFR 15 threshold for vascular access planning. The utility of the different thresholds needs to be implemented in the context of harm versus benefit. In patients with low harm of unnecessary surgery, KFRE 40, 30, or EGFR 15 could be considered depending on patient characteristics. when important to avoid the harm of unnecessary surgery using a KFRE 50 threshold or KFRE 40 in combination with EGFR 15 threshold is the more optimal strategy. Overall, KFRE 40 seems to have the best utility over the entire range of harm-benefit ratios. Reporting KFRE in the healthcare electronic system could be a helpful decision tool with the potential to improve the share of patients starting hemodialysis in an AV access, or at least to use it in the pre-dialysis clinic. To further improve outcomes, new risk prediction models specifically developed for CKD stage 5 are needed, incorporating factors influencing both KRT risk and mortality in the competing risk of death setting. Thank you for this honor to present our clinical research. Thanks also to all my collaborators. I also want to thank my colleagues and my patients. Thank you.
Fantastic. Thank you so much, Ulrika, for an extremely clear and thorough presentation. So it looks like we've got a question in the chat, actually, along the lines of some of the discussion that we were having just before the presentation. So the first question is really, I guess, both to you and to our panel expert, Professor Tangri, how will KFRE be used when kidney protection therapies become more widely used?
Ulrika, you can go first if you like. Yeah.
You can go ahead. It's what was the question? How it should be used if
once kidney protection therapies, SGLT2s, GLP-1s, finerenone become more prevalent.
Yes, we discussed that beforehand. This was one of my questions to Professor Tangri, but it takes a while. The kidney failure risk equation came a few years ago, and then the new medications is coming along. So you said you were going to maybe rearrange, look into the model further on. Yeah,
I'm happy to kind of add to that, and thank you again. I wanted to use the clap function on Zoom, but I couldn't find it in the webinar. So thank you for the great presentation. I think there's a few things. So first, we've been very thoughtful about this. The original publication was in 2011. Then 5 years later, we validated. 5 years later, we did another large validation because we want to see if there's any drift in the calibration in particular. We don't really think the relationship between albuminuria, GFR, age, and sex with kidney failure is changing, but we think calibration is changing. The baseline hazard is changing in the model over time. And I think it's going to change when we have really high meaningful therapies of proportion of people with kidney protective therapy, and it just hasn't happened yet despite all of our efforts. I think this is a slight sidetrack, but all of us on this panel, the attendees, are strong proponents of kidney protective therapies, especially for high-risk patients, right? You'd have unanimous votes here. But the reality is that when you look in the literature and you look in clinical data sets, 50% of patients are on therapy at 2 years. It's a 25% drop off every year. So I think it's a sobering message, and we will keep looking every few years, trust us, if there's a calibration adjustment or a drift needed. But it's probably equally important to emphasize that starting someone on therapy is not enough. We have to kind of keep it going because there are many reasons. Our patients are sick all the time. They're in hospital. Something gets stopped, and it just never gets restarted again.
Fantastic. Thank you very much, Professor Tangri and Ulrika, for that answer. I guess one other question from the audience relating to sort of timing of creation and sort of types of devices, I guess really probably goes more to Mr. Inston, is sort of are these sort of parameters applicable to all types of access? Is there sort of specific variations, particular towards intravascular devices, and sort of what are the recommendations with those, and sort of what situations would they be recommended as opposed to sort of natural access, which is the real sort of aim for us all, really?
Sure, I think that's a really good point, is that why do we need a lead-in time at all for this? And if we had 100% maturation from fistulas and nephrologists could refer to a surgeon and were confident that they would get a working access quickly, we wouldn't even be here discussing this. But the problem is that fistulas aren't very good, or we're not very good at creating things that work. To do access surgery, you've got to have fairly broad shoulders. Although a working fistula is, of course, the best access, it's not the quickest access. And what we're trying to factor in with this is failures and repeating the creation of an access for when it's failed. And in the best hands, you'll still get 20% failure rate in fistula creation, autologous fistula creation. Majority of studies have shown that, and it's pretty reproducible in most of those studies, and that's largely a biological or a selection issue. So we're going to have to repeat fistulas in a certain amount of people, which leads us back into this whole thing that we need to have an optimized pathway to make this work. And I can understand why people have started to refer earlier and earlier for fistulas, because they're waiting longer and longer for fistulas to be created. And then for the assessment as to whether or not you need a second fistula or a maturation procedure, again, is not standardized across the whole of Europe, across the whole of the world. So I think the issue with this is that we ain't got a great procedure. Actually, if lines were good, lines would be an optimum form of access, but they're not. And I think that's why a lot of patients do choose it, because it's, a line's in and you can use it straight away. There are some studies going on regarding AV grafts that can be used, rapid access grafts. Again, there are more interventions, there are more problems and more infections. But in certain patients, that may be a better procedure. There's certain studies going on to do that. I would add that the data set for vascular access is pretty poor compared with many of the other things that we discuss. So actually assessing that data and put it into place is not easy. And it comes back to, we'll come on to that in a second, but you specifically asked about devices. Is there anything new coming in? And there's not very many things. There is a device called the VasQ device. I won't go into it too much, which may have some benefits in terms of maturation and slightly better outcomes, but we're still going to be looking at 10 to 20% failure rate, which we'll have to factor in. And I think that whole pathway needs to be factored in as to whether it's referral for assessment or whether it's referral for creation of fistula. And when you create the access is what we need some guidance on. I think this is where, all the people on this panel are really important in adding to that data.
Fantastic. Thanks so much, Nicholas. I guess following on from that, one of the discussions that we were having sort of before this journal club was sort of what really would, or when would be the sort of, in real terms, the sort of realistic and practical timing to indicate the right time for vascular access creation. And obviously KFRE helps for that. And one of the sort of key sort of messages from our discussion was, well, it really depends on your setting. And I think you had some sort of important points on that, Professor Tangri, from your own experience.
Yeah, thank you. I think I just wanted to reflect that different settings have different access to surgeons, as Nicholas just pointed out as well. In particular, in my hospital, that we have interventional nephrologists who are putting in PD catheters at the bedside, and they're getting, our time to PD catheter is less than 5 days on average. So we actually don't use a threshold to refer early for a PD catheter insertion. But and whereas at another center, if a PD catheter is mostly done by surgeons, you may need, again, a lead time, and maybe that time is more or less than for a fistula. And this is where that 30, 40, 50% I think that Ulrika presented works really well. Like if you feel like you're at a place where you need a longer lead time, 30% might be the right threshold for you. And if you think that you're at a place where you need, you don't need a lot of time, then 50% might be the most appropriate. The authors can comment on that as well, but that's kind of our local practice.
Sorry.
I could comment on that because I think that's like a really important message, that you need to individualize the threshold according to the patient you have in front of you, but also according to what type of lead time that you're looking for. Because if you have, like Nicholas was talking about, if you want to place, for example, a graft that you can use quite soon, then you don't need such a long time before you actually refer to surgery. And then you might need only 6 months. And then our research show that actually you can look at the KFRE maybe 50%, then, because then you are sort of on the safe side also there. But most importantly, I think, is that our study also demonstrated that sort of at least Swedish nephrologists are quite good at selecting patients who will eventually start dialysis. But we miss those sort of uncertain patients. So we succeed in those where we place an access, but we tend to place the access too late, and we tend not to refer a large proportion of the patients at all or on time. So that is where the KFRE equation really would help, I think.
Fantastic. That's a really important message for all the audience, and I don't think that's just applicable to yourselves, Marie and Stockholm. I think we can all find examples of that in each of our own regions. Nicholas, I think you've got another comment that you'd like to make.
Yeah, it's just coming on to that really, is that I just wonder if anyone could comment on the use of this for, you said optimal timing, and we're kind of looking at 6 months to a year. Yeah, the tool was never designed for 6 months to a year. We're using a 2-year tool to try and predict things at 1 year. I just wonder if either Marie or Ulrika or Navdeep could comment on whether or not we should be looking at a separate vascular access prediction tool or the 2-year tool, because we're not perfect here with any of the studies that have come through.
From my perspective, what we tried to do, and actually some of this work was done by investigator at CK Dops, Chi Chu from UCSF. They published a nice paper in AJKD a couple of years ago, really graphing out the risk and the median time to dialysis. So after the paper, it was a figure. So after I sent him an email, I said, can you please send me the underlying Excel sheet from this figure? So what we did is we said 0 to 10%, 10 to 20%, 20 to 30% 2-year risk. What's the median and what's the interquartile range? So it's actually remarkably similar in Karolinska as it was in DOPS. So at 40%, it's 1 year, and you're probably looking at like either 6 to 9 months on the 25th percentile and up to 18 months on the 75th percentile. With this model, which I think is a fairly good model, you can probably get to 75% of the people. The last 25 are like very difficult to capture within. So that's about as good as I think this work gets. So maybe the other Ulrika can comment.
Yes, and I also use this the kidney failure risk equation to predict when, not just when the patients start dialysis, but when they will reach end-stage kidney disease. I mean, it's a great help when you plan the transplant investigation. I mean, at KFRE 30, I think of the vaccinations and the things that can be done in advance, and then when you approach, you start the things that needs to be done within the last year. So it's not just dialysis. I think it's to predict when they reach end-stage kidney disease.
The last quarter, to Nicholas, to further answer, the last quarter is the unsolved quarter. That's it might be something else, might be heart failure that gets them, might be an AKI. There's a quarter of people that you just can't get right.
To some extent, sorry, jumping in there, but to some extent, and I think the real interesting thing in this particular paper is the discussion about benefit versus harm. And a lot of people consider a fistula as harmless, but it may be minor surgery. If it doesn't work, it might not be harm. But what we often do and see is we lose those patients, and we've lost their confidence in that fistula is the best vascular access. And it's very difficult to convince someone that it's best vascular access when one's failed. And particularly in these pre-dialysis patients that I think are in a very vulnerable situation, that the earlier that we're starting this, and a fistula is a very sort of manifest way of saying that you're coming towards end stage renal failure. And for those patients that don't reach end stage, you have a fistula. There's not many studies been done, but I think the psychological impact of that and the social impact of that is really important in terms of the harm to be considered. So it's not just missing those that we can actually do a more rapid intervention and get them onto fistulas if they start on a line. But it's those patients who never needed a fistula in the first place that I think is a really important area here, because I think it's been commented in other papers that the resource issues with that are also quite significant.
I see you got your hand up.
Yeah, I want to take a minute here and maybe use my fellow panelists to see if they agree with me to can we put a pin in the insertion of fistula as associated with an improving in EGFR slope literature? Because this is the worst. I've seen so much of this in the last couple of years. And it's clearly, to me, a regression to the mean. You know, the physician is putting in the fistula when they're seeing the patient declining. So of course, after the fistula, the GFR looks like it stabilizes. So for all the audience here, we can maybe let them know that the fistula is not going to cure CKD progression.
So we actually did a paper, Ulrika did a paper on this in NDT a couple of years ago, where we actually demonstrated that placing an AV access did not didn't do anything to retard the progression. The progression retards anyway, because it was similar to when you create a PD access, because you place the access when it's when it's time to plan for dialysis, more than anything else.
On cue, someone had asked that question. I didn't even know. So this it's like psychic vibes.
Yeah.
Excellent. So I think we've had a fantastic discussion, and huge thanks to all of you again. So I think we probably need to hold time on our e-seminar today. So for all the ERA Journal Club team, huge thanks to go to Dr. Hahn, Lundström, Dr. Evans, Mr. Inston, and Professor Tangri for sparing us your time today and for sharing the exciting paper and all your fascinating insights. Please do, to the audience members, go to the NDT website and read this paper and the other paper that Dr. Evans just mentioned, and also do check out CKJ and NDT website for other papers covering this topic. And just recently, in fact, in the April issue of CKJ, there was a paper by Bernardo Marquez de Silva on generalizing the use of KFRE for better vascular access planning, as well as several other papers on a similar direction in February and January. So it's clearly a very important and timely discussion that we're having. So as always, please go ahead and answer the survey within the Zoom. Link will appear shortly, and we appreciate all your feedback, because these really do help keep the e-seminars running and develop the future formats. And we would prefer, if you would prefer a shorter format or any other sort of specific topics, please do let us know. But for now, it's goodbye from myself and the panel and the external moderators, and all the team at the ERA, as well as my co-moderator Will, to say thank you and goodbye.